Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Welcome to the Gastro Girl podcast. I'm your host, Jacqueline Gollin, and I'm thrilled to bring you another important discussion that directly impacts our digestive health and overall well-being. Colorectal cancer is one of the most preventable cancers, yet many people still don't get screened on time. We're also seeing an alarming rise in colorectal cancer cases in younger adults, and disparities in screening access continue to put certain communities at higher risk. To help us better understand this critical issue, we're honored to have Dr. Reezwana Chowdhury with us today. Dr. Chowdhury is a leading gastroenterologist at Johns Hopkins and currently serves as chair of the American College of Gastroenterology's Public Relations Committee. She is also chair of the membership committee of the South Asian IBD Alliance. Now, Dr. Chowdhury specializes in Crohn's disease, ulcerative colitis, and colorectal cancer screening, and has dedicated her career to raising awareness about inflammatory bowel disease and colorectal cancer prevention. Her research focuses on early-onset CRC trends, IBD-related colorectal cancer risk, and disparities in screening access. Dr. Chowdhury, welcome to the Gastro Girl podcast. It's so great to have you on the show today.
Thank you so much for having me. I'm really excited to join you. I've heard so much about this podcast.
Well, hopefully it'll live up to your things that you heard about it. Or maybe
I have wonderful things. So I feel very honored.
We're honored to have you on the show, especially during a topic that's so near and dear to your heart. I saw, on the socials, you were just in the DC area with ACG and, really advocating for colorectal cancer awareness on Capitol Hill and raising awareness. It's so amazing what everyone does. I saw those flags and, it's really something that I know you're very passionate about. And also through your work at the ACGs, you're chair of the Public Relations Committee, which is a huge role and a very important role, especially when it comes to important issues like colorectal cancer awareness. So let's begin with, explaining, we hear about it on the news, but I think you can never hear about it too much. Why is colorectal cancer screening so important?
So colorectal cancer has been on the rise in individuals younger than the age of 50, actually, in the last couple of years. At this time, we expect about 107,000 new cases of colorectal cancer in this next year, and then about 47,000 new cases of rectal cancer. And overall, the lifetime risk of developing colon cancer in men is about 1 in 24 and 1 in 26 for women. I mean, these are pretty high, like just amongst all of us in our colleagues, like one of us will be diagnosed with colorectal cancer. And in the US, colorectal cancer is the third leading cause of cancer-related deaths in men, fourth leading cause of cancer-related deaths in women, but it's the second most cause of cancer deaths when the numbers are combined. And it's about, the number is expected to be about 53,000 deaths during 2025 from colorectal cancer.
This is really alarming. And we're going to get into even the young onset, which I think is really spiking the numbers. We'll talk a little bit about that. But, what are people always want to know, how can I prevent something like cancer or colorectal cancer? So what are the biggest risk factors for colorectal cancer?
So there are many risk factors, but the biggest ones are ones that would be associated with many of the cancers. So smoking, tobacco use is associated with all, like when I counsel my patients, I'm like, pretty much smoking, you've increased your risk of any type of cancer, colorectal cancer being one of them as well. Alcohol use has been associated, our diet these days, increase in processed foods, increase in processed meats, red meats, obesity, diabetes, and then a family history, genetic reasons as well are associated with this increased risk of colon cancer.
And what about for people that have something called inflammatory bowel disease? Are they more at risk?
Yes. So I'm actually an inflammatory bowel disease specialist. So one thing with inflammatory bowel disease is basically it's inflammation. And we know inflammation does drive to these precancerous changes, ultimately potentially leading to cancer. So inflammatory bowel disease patients or patients with inflammatory bowel disease are oftentimes diagnosed at younger ages. So they've had this inflammation underlying for a lot longer than maybe the average person who hasn't had inflammation. So longer inflammation, as we stated before, does increase your risk of cancer. So inflammatory bowel disease patients are definitely at higher risk and not considered average. So they wouldn't be following, when we speak about guidelines, average risk guidelines.
Yeah, and that's our next question. There's often confusion. Originally, the screening age was 50, and for African Americans and others, others at high risk, it was younger at 45.
Yeah.
But the ACG updated its guidelines a few years ago. Could you explain what the guidelines, most current guidelines, say in terms of when to start screening?
So it's not even just ACG, it's even American Cancer Society.
Great.
It's all of the organizations now, basically starting age for an average risk person. So basically someone that is average risk is someone that has no family history of colon cancer or early colorectal polyps in their family members or history of inflammatory bowel disease. They would start at the age of 45. So that would be someone who has no symptoms and no family history. Screening is recommended starting at the age of 45.
No, I'm so glad you pointed that out. It's great to see all the different organizations on the same page because I think previously, I remember when I first started doing work with ACG, there was different ages and there was even more confusion. So it's great to see everyone coming together
Yeah,
on this really important issue so patients aren't confused.
exactly.
So that's, and as we talk about screening, there's obviously the gold standard, which is the colonoscopy, but there's been other stool tests, and even there's some blood-based tests that even confuses us even more. So I want you to just walk us through the screening options and why colonoscopy is a little different than the others.
So, what I like to tell my patients is any form of screening is better than no screening at all. So, if they're not interested in doing a colonoscopy at this time, stool-based tests are good and they're adequate if you are again average risk. This does not apply to anyone that is high risk. Now, in terms of why colonoscopy is a gold standard, if any of these other tests are positive, ultimately you're going to need the colonoscopy. And, unfortunately, there have been cases of these negative stool tests. And when we do these colonoscopies for potentially other issues, they may have diarrhea down the road or abdominal pain, and someone wants to, they've ordered that procedure. Oftentimes, we still find a lot of these precancerous polyps. So, what the colonoscopy does is when we find these polyps, we remove them, thereby reducing the risk of colon cancer. And so, with the average risk patient who is just completely averse to wanting to get a colonoscopy because they may be worried about sedation, they may have issues with getting a ride to a procedure. Unfortunately, some of these preps may be expensive and insurance issues, which is, something we're also hoping we won't have to battle for screening purposes down the road. But, there are many things that may deter them from wanting to get a colonoscopy. So if they're average risk, I'm perfectly fine with them getting at least some sort of stool-based test or some sort of screening method. So it's just having that conversation, but also explaining to that patient that, hey, if these aren't all of these are not other factors, it's kind of a one-stop shop. If you come in, your colonoscopy is clear, we don't find polyps, you're good for 10 years. You don't have to see me again. So you're off the hook. However, you can do this test, and then if that's positive, then ultimately you will need that colonoscopy. So it's just trying to understand what kind of barriers they may have, but also the patients recognizing that there's a reason the colonoscopy is the gold standard. And, if you're able to, and, if you're able to and you're not high risk, that would be what my preferred method would be.
Oh, no, thank you for that. Now, I want to get into sort of the signs and symptoms, and especially as it relates to early onset colorectal cancer, as we're seeing the trends
Yeah.
really increase at alarming rates.
Yeah.
Why do you think this is happening? I know that's like the $1,000,000 question, but what's your take on
I think
this?
if I knew that, I would be like, but I think one thing is that we've gotten much better at screening older individuals. So I think for a long time, this has been a disease of maybe people 50 and over, which is why the rates for 50 and over are actually have been decreasing, whereas the rates for younger are upticking. So in terms of screening methods, I think younger folks don't think they need a colonoscopy because they're too young. It's not a disease for them. I do think that our diet probably has not improved with time. It's only probably worsened with the things that we eat these days. The obesity pandemic, we do know there's some association with obesity and increased risk of colorectal cancer. Having a sedentary lifestyle, that all of these can contribute. So, all of this potentially altering our gut microbiome, just these are things that we're studying, trying to figure out. But I think the issue may be that, younger folks just may think it's not their disease, that, they have time to figure before they need to actually worry about colon cancer.
Yeah, that's great insight. And if you could expand on that, let's go into some of the signs and symptoms that might be ignored. Maybe someone thinks they have hemorrhoids if they have a little bleeding, and maybe other things we're so used to just like sucking things up and dealing with it. Oh, it's something I ate that was bad, or it
Yeah.
doesn't happen to me. I'm too young. Like,
Yeah.
what are some of the signs and symptoms, especially what you've seen your patients come in and maybe they're at stage 2, 3, or 4, and they said, God, I wish I would have paid attention a long time ago.
I mean, what scares me more are the ones that don't even have signs oftentimes, like
Oh,
that are
wow.
for that first 45-year-old, like, screening and you're like, "What? You had 0 symptoms? Like nothing?" So, I mean, again, we do know that whole without symptoms does exist. So we don't want to, symptoms for sure, but even without symptoms, screening should be started or at a minimum of 45.
Yeah.
So, in terms of signs and symptoms, abdominal pain that's out of the norm, that's new. Changes in your bowel habit. If you're someone that was going regular forever, for the longest time, and then suddenly you're having more issues, diarrhea could actually be a symptom of it, or constipation, meaning you're just not able to get that stool out, or your stool caliber has changed. Now it's like what we call pencil thin, but it's just the caliber is different. Obviously, if you see any blood, that right there for me is a red flag. And I don't minimize anyone saying, oh, I see a little bit of blood with wiping, or I see blood here and there. Like to me, blood, you've earned a colonoscopy because there's absolutely no reason why I wouldn't take a look and just make sure that it's absolutely nothing other than maybe hemorrhoids is what if that's what you're writing it off to. And then many patients can have symptoms of bloating. If you're getting just routine blood work and your blood work shows anemia, that's also very important.
Oh, interesting.
Why are you having this blood loss that you may not actually see, but clearly you're losing it somewhere? That right there is a subtle sign.
Oh, that's really important. Thanks for pointing that out. And now you've done so much amazing work advocating. You just were on the Hill with ACG and all the other great colon cancer foundations and patient advocacy organizations. When you speak, what is your recommendation for how do we encourage younger adults to pay attention to the symptoms and advocate for screening? Sometimes, I'm not saying all doctors, but we may encounter a healthcare provider who could be, and we've heard from patients that they were dismissed. Oh, you're too young. Don't worry about it. What is your advice for patients?
So I think some of the outreach that all these organizations are doing is very important, and all of us who are at least reaching out on social media and then try and encouraging our colleagues and whatnot to spread the word. I think one thing that we're actually going to be doing here at Hopkins is we're going to actually be organizing a 5K. We're going to bring our primary care physicians to join us and just talk more about colorectal cancer screening. Like it doesn't have to be the colonoscopy if your patients don't want to, but at least get them screened in some form. So I think just all the different ways we're doing outreach. I mean, your podcast, I listened to the one last year, the Tune It Up concert, and all the different organizations that are just, getting out there to spread the word. And then, my young patients, hey, just because you're 30 or 40, that really doesn't mean you're not at risk, unfortunately. So we're not going to take this light and we're going to investigate. And then the worst thing, or the best or worst, however you want to take it, is you have the procedure and we find nothing. That's assurance for you. And if we catch colorectal cancer early, that the 5-year survival rate is 90% at an early stage. So even if we catch it early, you still have a long survival rate. It's just when the stages get later that goes down. So if it was, if we catch it, your survival is still, in the 90th percentile, I guess, if you want to put it that way.
Yeah, no. And that's what I was always so fascinated about with the colonoscopy. You can actually, remove it before it turns into cancer or a precancerous polyp. And that's really preventing this from getting worse. And I don't know too many cancers you can do that with.
No, exactly.
Wow. Now, as we talk about screening, the reality is that not everyone has access to care, let alone screening. And there are, unfortunately, underserved populations and screening disparities. In your experience and in your viewpoint, what are some of the biggest barriers to CRC screening in underserved communities?
I think one is probably access in terms of availability of access to physicians, access to gastroenterology practices that that are able to perform these colonoscopies. And then really just maybe lack of awareness on updated guidelines that, hey, 45 is really the new screening age. Really kind of folks potentially maybe not knowing family history maybe not having genetic, if they have other cancers, potentially genetic syndromes that may increase their risk.
And not everyone's on there has a phone or the internet. So it's more grassroots, right? There have been organizations that go into the churches, they go into community centers, they go into places where people are meeting and gathering, and hair salons. I read, barbershop.
Yeah. And they won some awards from us. Because those are just very creative ways that they're trying to get the word out. So it really is like, the onus is on us as like gastroenterologists and the physicians to really make sure that we are educating everyone and not just the ones that come to see us, finding ways to reach out to communities that may not have access.
Now, obviously, there's other factors such as economic, cultural, and systemic. There may be some misperceptions about and some, hesitation just about the procedure, colonoscopy itself, that may contribute to some of these disparities in screening access. And how, in your opinion, what are some of these that could be impacting this serious issue?
So I think, I think for a long time we've known that like the risk has been higher in African Americans. So the screening age has been recommended earlier. I mean, the risk is high in, American Indians, Alaskan Natives. Now, is that because of not enough or like lack of access? And the rates are actually quite high in South Asian populations. And I don't think many South Asians, being South Asian myself, necessarily think that colorectal cancer screening is important. I mean, they're all on top of getting their mammograms because they've done, they know that breast cancer is on the rise, and that's also one of the in younger women and potentially men. But they are not really. There's just this hesitation of, do I really need a colonoscopy? Like, colon cancer doesn't run in my family. Oh, it hasn't happened to all these people who've lived this long, but they've lived here. This is the new diet, and then now with the globalization of the world, diet kind of seeping into all locations, a similar diet. That could be increasing the risk in these other countries as well. So I think just kind of maybe the stigma behind a colonoscopy, or just kind of reiterating that, any race really is at risk, and you really just screening is just so important. So again, like you said, people going to churches, potentially going to temple, going to mosques, going to synagogues, like these are all important measures. And then going to local community centers, just where people gather. And then honestly, just word of mouth, like you have a gathering of some of your colleagues and just, hey, how old are you? Oh, you need to get screened. I mean, I have actually done that.
No, that's awesome. And, the family thing, I grew up in an Italian Catholic family, and we weren't talking about health issues. I think maybe that's, I don't know if it's a family thing, or if it's a generational, or if it's a ethnic thing, that people don't like to talk about negative things, right? They kind of don't. And so kids, we don't know.
Yeah.
Now we're adults, but back then we didn't know. Like, I don't really know what my grandfather died of. I mean, my mom said one thing, but it doesn't make sense. You know what I mean? Like, is that at play here too?
Yeah, absolutely. Because many times, when we're consenting our patients for the colonoscopy, hey, do you have a family history of colon cancer? And many, I've had many patients who are like, there's some cancer. It might have gone to the colon. I don't know if it started somewhere in the abdomen. And it's like, okay. And I get it. I mean, it isn't something that necessarily people talk about, but again, I think it is something that it's our job to just make sure we go out there and really just emphasize that it's important to discuss this. It doesn't have to be at dinner. It can be on a walk, just have that conversation. Has there ever been anyone that's passed away from cancer? If so, potentially what type? Does that make me high risk? And, just breaking the stigma of the colonoscopy.
But this brings me to, I don't know if it was a few years ago. It was either the Colorectal Cancer Alliance or Fight CRC, or both of them. They had this amazing resources for talking to, it was this whole campaign about talking to your family, how to talk to your family, to get the family history. Because it's exactly what you said. Yeah. It's hard to have that conversation. And they gave great tips, great scenarios for kind of getting that information, because it can really be beneficial. You may not think, and it's not just an immediate relative. It could be like a couple back, right?
Yeah. Yeah. And if it's a couple, like not even just one, if it's like a couple, like multiple, and then also ages are important. If they were diagnosed in their early, like before the age of 50, that's definitely higher risk than someone that potentially was diagnosed at a later age. Wow. And again, family history of inflammatory bowel disease or personal history of inflammatory bowel disease. And I think just, something else, I think we just have to break the stigma in many of our communities, and then just really kind of get the word out there.
Yeah, I love work. I loved reading stories, and I think there was some Scopy winners over the years where
Yeah.
they, a lot of the communities, they trust what goes on in their community center or a local pasture or a church leader or mosque, or
Yeah.
they trust their community. So to really, that's a huge part of this, is having that trust, because
Yeah.
sometimes there is a distrust with healthcare providers. I
Yeah.
saw my mom was a nurse. She never wanted to go to the doctor, and she knew better, right? But I think those programs are so powerful
Yeah.
on the community level. And I want to, really get into your work with the South Asian community, because you mentioned it's not always talked about, it's not always recognized. And
Yeah.
I know that group has been doing such amazing work in educating. It's, Tina and team, they've just really
Yeah.
raised the bar on, giving it the publicity and the visibility that it
Yeah.
hasn't had in a long time.
Yeah.
So can
And
you
they
talk?
talk about everything. Yeah, so I just recently became chair of their membership committee, the South Asian Indian Alliance, and I'm just very honored to be working with them because I've just been so in awe of what they've been doing over the last couple of years. I mean, they're literally on the forefront of, research in inflammatory
Yeah,
bowel disease, and then they are out there talking about colon cancer, just everything IBD and related. And they do a great job in trying to reach out to all these countries. I mean, there's so many countries in South Asia that are part of this and that are now recognizing this. And I think the effort that they're making, and we're, now that I'm part of that committee as well, that we're hoping to make is just to really, get the word out there. Where, I mean, ACG as well, even with SAIA, I mean, there's a lot of South Asian countries that are getting the translated like patient forms. And so they have the translation of like colon cancer risks and how you can get screened in various languages. If you even go to the ACG website, that physicians are able to get and then hand to patients who have, who speak other languages or may read other languages. And so, they work closely with all these different organizations just to get the word out on like colorectal diseases or GI
that's
diseases.
amazing. That's
Yeah.
amazing, especially with the increased incident, like you
Yeah.
mentioned earlier, in digestive health. Whatever the reason, there's definitely things going on, and we've had a lot of people from India watch our podcasts. Like if you look at the demographics, so it's obviously a hot topic in
Yeah.
those countries.
Yeah,
For
absolutely.
instance, for example, now, what can individuals in the South Asian community do to protect their digestive health and advocate for CRC screening, in your opinion? I know that's probably a lot of different ways to look at this, but just, as we have this discussion, and our listeners are hopefully listening in, taking notes, like what what can they do?
I mean, I think, like South Asians as well as, just any patient, one, if you have symptoms and some of the symptoms that I mentioned, if you feel like you're potentially getting them dismissed, you do need to find someone else that will listen to you and and, hear you and want to investigate it further. It doesn't necessarily always mean a colonoscopy, but at least investigate it further in some way. Um, and also, I think the biggest thing for South Asians really is like just not assuming that this isn't something that they're going to be afflicted by, that this isn't something that, that they're not going to, that's going to touch them. This is a very real cancer in this population as well. And it is equally important for them to be screened. Now, I guess in terms of advocacy, I mean, whether I have a South Asian patient or not, I look at age and risk factors, and that's how we decide screening.
Yeah,
I would hope no one would ever, minimize it just based on race in any way.
no, that's important. Um, No, I want to go back to your comments about IBD and colorectal cancer risk, because this is a really big topic. We know that IBD is also increasing.
Yeah.
Um, I've never, since I first started in digestive health, just the amount of people that you run into that someone's affected by IBD in some way or another is really mind blowing.
Yeah. Yeah.
And can you reiterate why people with Crohn's and ulcerative colitis are at increased risk? Because for those listeners who do have some form of inflammatory bowel disease, I don't think we can stress this enough. So I'm going to ask you again before we close up. Why are they at increased risk, and why should they pay attention to this?
So Crohn's can affect any part of the GI tract, and obviously ulcerative colitis is inflammation that's confined to the colon. That inflammation, oftentimes these patients present at much younger ages. and they've lived with this inflammation long term. And we know that after a certain amount of time, that inflammation, if it goes unchecked, does increase your risk of colon cancer. So oftentimes our IBD patients are diagnosed at the age of 10, 12, like they're pediatric. So they've lived with this inflammation for a long time. So they can't wait till 45 to have their first colonoscopy because they have had inflammation for at least 3 decades at that point. And we know that having inflammation, even unchecked or, even if you're not having symptoms from your inflammation, if there's inflammation in that colon, you're still at risk for colon cancer developing. So it's very important for you to, one, work with your IBD provider. We work on getting your inflammation down. But even once your inflammation is in check, having had that inflammation puts you at risk. You're a higher risk individual. And your colonoscopy is not going to be the standard 10 years, even if we don't find polyps. Your colonoscopies are going to be more frequent because you're just at risk for it.
Yeah, no, thanks. So how do the screening guidelines differ for patients with IBD?
So with ulcerative colitis, when it involves more than just the rectum and you've had the disease for at least 10 years, you are going to get screened every 1 to 3 years, depending on the level of inflammation that we see, any early, like precancerous or early cancerous changes. And that's the same that applies for Crohn's. So if the inflammation involves your colon, and it's been present for at least close to 8 to 10 years, we're going to start screening you once you've hit the 8 to 10 year mark, and then you're going to get screened or get a colonoscopy. Now unfortunately, you're not going to be a stool card candidate. You're going to need to get screened every 1 to 3 years, again, depending on what we find. And those guidelines vary with different organizations. Some say you can wait even 5 years. And if you have a history of PSC, primary sclerosing cholangitis, which can oftentimes be seen in patients with ulcerative colitis, you're at much higher risk for colon cancer. So you're actually going to be on a 1-year screening protocol, getting colonoscopies every year.
Wow. Now, it seems like a lot, but don't most IBD patients get colonoscopies regularly anyway, just to check how their colon is doing? Or
they do.
So
they do. But I mean, a patient that's been in clinical remission for a while on the same medicine, you don't need to do a colonoscopy unless they're due for their surveillance.
So this may be a wishful thinking question, but what proactive steps can patients with IBD do to reduce their long-term risk of colon cancer, colorectal cancer?
One, I think the most important thing is working with their IBD provider and working on getting their inflammation in check. So that's going to be the biggest risk factor, or the biggest modifying thing they can do is just try to get that inflammation under control with their IBD provider.
This has been such an important conversation, and it's been very insightful. We can never talk too much about colorectal cancer awareness. There's so many angles to look at this from, and really addressing those underserved populations. And the South Asian community is so important, and I'm glad we had a chance to discuss this with you who know this so well. Do you have any final thoughts or takeaways for our listeners that you'd like to leave us with?
So the biggest thing is colorectal cancer, again, is on the rise for folks that are younger. So I would, just recommend that you talk to your provider, your healthcare provider, whether it's your primary care physician, your OBGYN, whichever provider you have, just to discuss your risks and then determine what screening method is appropriate for you. Again, if you're average risk, you can do a non-invasive testing method. But always remember, colonoscopy is the gold standard because we can reduce your risk of colon cancer by removing any precancerous polyps. So really, the biggest take-home point for me is just please get screened. And if you have any symptoms, please don't ignore them and don't wait for them to become so severe that you're coming and seeing us at a later stage. Because if you start to develop symptoms, we catch you early, your long-term survival is much higher than if we catch you later.
Thank you so much. And before you go, I want to just tap your wonderful brain one more time. Are there any suggested resources or events or advocacy organizations that patients should know about for more information that you suggest?
So I think one is the American College of Gastroenterology website, where there's a lot of patient information and patient handouts that patients can read through in terms of colon cancer risk and the various screening methods. I know that the same would probably all of our gastroenterology societies, so American Gastroenterology Association, American Society of Gastrointestinal Endoscopy, the South Asian IBD Alliance does a lot of outreach work. So anything that they put out is also discusses colon cancer and inflammatory bowel disease. Crohn's Colitis Foundation also talks about inflammatory bowel disease and colon cancer. And then there's the Fight CRC group, who just does wonderful things on social media in terms of getting the word out and different events that are being hosted. And the Colorectal Cancer Alliance, I think, is another great one that patients can look at. I mean, they're constantly giving out these scary statistics that you're like, I can't ignore this, or I shouldn't.
Oh, thank you so much, Dr. Chowdhury, for joining us today again. And to our listeners, remember, colorectal cancer is preventable when it's caught early. So if you're due for a screening and you're 45, happy birthday to you. Go get screened. It's not that bad at all. I've had 2, and actually it's the best sleep I've ever had when I wake up, honestly. So don't be afraid of that. It's time to take action, and stay tuned for more episodes of Gastro Girl, the Gastro Girl podcast. And don't forget to like, subscribe, and share this episode so more people are aware of the wonderful work that Dr. Chowdhury is doing to raise awareness about colorectal cancer. Thank you so much.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.